Hey everybody, and welcome to Community Conversations. My name is Luke Margolis. I'm the Corporate Communications Director for Atlantic Health, and today I'm excited to be joined by Dr. Matthew Grossman. He is an interventional endoscopist and gastroenterologist with Atlantic Digestive Health Institute. Doctor, good to see you, sir.
Thank you for having me.
I'm looking forward to chatting with you today. We have a ceremonial reason we're here. March is Colorectal Cancer Awareness Month, hence we always have a blue backdrop, but we'll give extra credit for it today.
Absolutely. Well, it's the happiest month in the GI office for sure. It's like Christmas time for us.
The busiest at the very least, I'm
Exactly,
sure.
exactly.
Well, and that's our hope too, right? Because I think partially what we're here to chat about today is raising awareness about the importance of screening for colorectal cancer. But we also are going to talk about some of the interesting things that are going on in the treatment space, and some really useful information for you to know, for you to share with your friends and family, because colorectal cancer is, for statistics that I know you'll share, a disease you're certainly going to want to know well in advance of it and be ready to combat, should it be something you have to deal with. Doctor, before we get started though, let me just tell folks, if you miss any portion of our conversation today, you can find all of our community conversations at our website, atlantichealth.org. We have done almost 40 of these, give or take, so there's plenty of cool things for you to learn about there, other physicians for you to hear from, and we encourage you to also subscribe to our YouTube channel, where you're seeing this now, so that you never miss any community conversations, because that would be a tragedy. We don't want that. So, all right, doctor, you ready?
I'm ready.
All right. So, interventional endoscopist. Easy for me to say. What exactly is the kind of work you do? What does an endoscopist do?
So all GI doctors will perform endoscopies, basic routine endoscopies, looking down the mouth into your esophagus, into your stomach, into your small intestine, up the bottom, and looking into the colon. Interventional endoscopists go a bit deeper. We can go beyond the walls of the GI tract, deep into the walls for early stage cancers. We can resect them and carve them off the walls of the stomach and colon. We can go into the liver, into the pancreas using endoscopic ultrasound, and look through the stomach as a portal to the rest of your abdomen. So nothing is off limits for interventional GI. It's a very exciting field, a lot of high-tech instruments and a lot of fun technology to work with.
Deeper metaphorically and physically from the sounds of it. I want to pick up on the last part you mentioned, the technology element of it. It seems like there are advancements coming every day in the technology you use. How exciting is it to be a part of a field that's evolving so quickly?
I love it. The tech is what keeps me waking up every morning, coming in excited. You never know what's around the corner. The latest advancements in endoscopy would blow you away. What we can accomplish with an endoscope was reserved for surgeons only decades ago. And we are at the point where some of my colleagues are referring to themselves as endoscopic surgeons because the technology is actually that advanced.
Wow, remarkable. As I said off the top, we are doing this in the month of March, which is an awareness month for colorectal cancer. And so part of what our mission really is to empower all of you with knowledge that can be so useful in maintaining your well-being and your health. So I'll start with a very broad one, and then we can dive deeper from there. When it comes to colorectal cancer, how important is the screening portion of it, that early notification?
The most important. I cannot tell you how important it is for you and your loved ones to undergo screening. And screening doesn't have to mean undergoing a colonoscopy. There's other modalities, but the whole point is early detection. And why? Why early detection? If you detect a colon cancer early, when it's a precancerous polyp, we can resect it and cure it, and it will never become a cancer. Or if it's an early stage cancer, survival and cure of those early stage cancers can be upwards of 90%. But in later stages, survival is very poor. So if you do not get a screening test and the cancer presents itself in the later stages, survival is actually quite dismal. And additionally, it's interesting. The guidelines for screening, it used to be at age 50, your birthday present for that birthday
That
was a colonoscopy. But our societies have actually moved the screening guidelines upward, and 45 is the new 50. So we actually begin screening at age 45 because of a recent onslaught of young people with colon cancers. And these are real tragedies when they're diagnosed. And we're seeing that on a population-based health level. If we move up the age of screening colonoscopy, we will detect more early cancers and advanced polyps that when we resect will be curative.
All right, folks, so you heard that. 45 is the new 50. Easy to
That's
keep in
right,
mind.
right.
And it sounds like what you're articulating is that it really truly is, it can be a life or death difference for some folks between catching this early and not. Is it always colonoscopy? What are some of the different screening opportunities we provide for people here?
So colonoscopy, I think, is the gold standard. I think most GI doctors would agree with me on that. Why? Because, first of all, colonoscopy is both diagnostic and therapeutic. So if we find a polyp on a colonoscopy, we remove it.
You can
right
do something
then and there.
about it.
Exactly.
Yeah.
So,
Okay.
but that being said, not everybody wishes to undergo colonoscopy. You have to prep for a colonoscopy. Everyone tells a story about their prep. I've heard many different tales, but the prep is.
You
not,
probably do get a lot of interesting stories in your line of work.
Yeah,
I'm
well,
sure.
it's not an enjoyable prep, but I've done one myself, and it's not that bad. The prep involves cleaning out the intestine so that we can visualize the lining of the bowel and find polyps. So that's the most important part of a colonoscopy, in my opinion, and that's up to the patient to comply with that prep and do their best job with it. But some screening modalities don't require prep. Right now, we can do two things. One is called fecal immunochemical testing, essentially checking for blood in the stool. And the other is Cologuard, which is a genetic test. Often those two are combined together. So you could do a screening colonoscopy every 10 years. Assuming you have no polyps, you wouldn't repeat a screening colonoscopy for 10 more years. You could do a Cologuard or a fecal immunochemical test every 3 years. Okay. If you do just blood testing alone in the stool, it's annual. So okay. Those are all options depending on patient preference. You could also perform flexible sigmoidoscopy, which doesn't require an oral prep, but often you'll take an enema prep for that. That is every 5 to 10 years. And I think it's an option for patients who don't have access to full colonoscopies in certain parts of the country. But in these parts, usually we have excellent patient access for full colonoscopy.
Here at Atlantic, we try to make, I guess, a wide array of these types of screenings available. Are the items you mentioned, if patients were interested in learning more about the offerings we provide here at Atlantic, do we offer all of the colonoscopy for sure?
Yeah,
certain.
Absolutely. So usually this will come from the primary care doc. So I can tell you at Atlantic Medical Group, we have an open access colonoscopy program. So assuming you're 45 years old or older and have no substantial medical problems that might prohibit a colonoscopy, you can just be referred for the colonoscopy, skip the visit to the GI doctor's office, and undergo the colonoscopy. You meet your doctor the day of the procedure. You'll have prepped. Our nurses call you up, give you prep instructions. That is the ultimate inconvenience, I think, for patients. Not every medical group has open access, so a visit to your GI doc is all it takes, and a quick discussion. It's a quick visit and a quick discussion about what it takes to prep for colonoscopy. Why are you doing this? We'll usually ask if you've had family history. Family history is a huge contributor to colon cancers. We see colon cancers running in families. There is a genetic correlation with colon cancers that can be inherited. If you have a strong family history, you may actually be in a high-risk category for colon cancer.
So if you're in your early 40s and you know you have a family history of this, it's pretty important you schedule a screening.
Absolutely. The guidelines even speak to this even further. So if you have a first-degree relative who has had colon cancer or advanced polyps, whatever age they were detected, you begin your screening 10 years prior to that age. So if dad had polyps at age 47, detected for whatever reason, you would begin at age 37. So, this is how far we've come in terms of the guidelines, understanding that this is a familial condition for many.
We have a lot of the information that you're hearing about today and a lot of the resources that we're discussing are easily accessible on our website. I would definitely encourage folks who are watching and want to learn a little bit more to check out atlantichealth.org/colorectal screening. All one word, no hyphens, just colorectal screening after the slash. And you can navigate to these kinds of things on our website too, but that's the shortest URL for it. And you'll find all kinds of important information there. Also through our Find a Doc link, you can find contact information for physicians like Dr. Grossman and others. If perhaps you don't have a primary care physician or a GI, or you're in need of any kind of services, you can find all those on our website. I'm wondering, Doctor, you talked about the ability to go in and for a colonoscopy to be both analytical, and there can be activity associated with it in terms of removing polyps. What's the recovery time for a patient after having a polyp removed? Is it extensive?
I often tell my patients that getting a colonoscopy is now like going to the spa. It's very relaxing because you receive sedation prior to the procedure. The procedure itself is painless. You should not fear any discomfort during the procedure. After the procedure, because of the way we perform colonoscopy, recovery is really a matter of minutes. You will go home the same day post-colonoscopy, and because we inflate the bowel, not with room air anymore, we use carbon dioxide to insufflate. Carbon dioxide is rapidly absorbed into your bloodstream and you exhale it. In yesteryears, we used to have patients who were very distended and bloated after this procedure, and for several hours they could remain that way until they passed the air. Now, with carbon dioxide insufflation, usually there's no discomfort post-procedure. And resection of a polyp as well is a painless procedure. You don't have pain fibers, nerve fibers in your colon the way that you do on your skin. So you don't even know that something has happened.
Wow, remarkable. Yeah. Well, I forgot to mention towards the top, and shame on me for doing so, but we always do ask folks who are watching, if you have any questions while the doctor and I are discussing this, to please feel free to throw them in there. And we do have a question. Amy asks, if you have any thoughts around maybe why colon cancer rates may have increased, particularly in younger people. Is there any science that sheds any light on the why we may have seen rates increase there?
Yeah, that's a brilliant question. I wish we knew why, because we would do something about it. But we can only point to big trends in society. What has changed in the youngest generations? We are more sedentary. We tend to eat a higher carbohydrate diet. We tend to be less outdoors, more indoors. So any one of these factors and a plethora of others might be invoked, but we really don't know why. All we do know is that this is an observation that we can make on a population level, and that has caused the biggest society recommendations to shift our guidelines from 50 years to 45 years. And quite honestly, any GI doctor, when you have any alarm symptoms of GI disease, and that means early satiety, when you eat something you feel full right away. It means bleeding in the GI tract, whether that's black colored stool or frank blood in the stool, unexplained weight loss, a change in your bowel habits. Those are all reasons, regardless of your age, that a doc may consider doing a colonoscopy. So the point is, for young people, we don't screen people below 45 years old. Right. But colon cancer can occur younger than that. And you need to talk to your doc. You need to speak up when you're having symptoms. It's not in your head. You're not imagining it. We want you to take these seriously and voice it, because this is the only way we're going to catch colon cancer in young people.
Wow, great question, Amy. Thank you so much for asking it. And folks, if you're following along and have a question, please feel free to put it into the chat function there on the screen, and I'll have it sent up to me, and we'll ask Dr. Grossman when it comes in. Something you and I were chatting about before we started, but I think is worth touching on, and we did a little bit in the beginning, this idea of it's an amazing time to be in the line of work you're in because of how far it's progressed. More to come? Do you see interesting things happening on the horizon in this space too?
Unbelievable what's happening. It's so exciting. In terms of colon cancer screening, I would say the cutting edge right now is the use of artificial intelligence to augment what's already going on in screening colonoscopy. So I should tell you, over the past 30 years, colonoscopes have gone from fiber optic scopes that doctors used to peer into and from very grainy images to high definition, beautiful 4K images that you can see the tiniest textural changes. And as a result, our detection rates have gone up. Colonoscopy is considered 100% accurate in detecting colon cancer, meaning if you have colon cancer, we're going to find it on a colonoscopy. And that's because the optics have come so far. And this is just like when you watch a football game on
you see it in the stuff you have at home, right?
It's different than it was in 1986 when it was a grainy image and you couldn't make out details. So this has enabled us to show that actually 50% or more of colon polyps are perfectly flat. We used to miss these polyps especially on the right side of the colon, the part that's far from the exit. We used to miss flat polyps all the time because our optics limited us. Now that we're using high definition scopes, we find these flat polyps, and docs like myself and other interventionalists can carve these flat polyps out before they become cancers. So that's the first step in technology. But now take that a step further, where artificial intelligence will be looking at your bowel during colonoscopy along with an endoscopist, and that artificial intelligence may highlight something that even with these fresh optics we don't pick up on. And this could even increase our detection rates further, lower mortality further, and this is cutting edge stuff right now.
We hear about the use of that in other applications here at Atlantic. I know we've had folks, our executives, talk about its use in radiology scans and things like that. It's an exciting time to be in the line of work you're in, for sure. Nicole has a question. Nicole would like to know, you talked about the 100% accuracy of a colonoscopy. What are your thoughts on the other testing methods we talked about, the screening methods we talked about earlier, Cologuard specifically? How reliable are a lot of these tests that we see that are not colonoscopies?
Right. So I don't have the stats memorized, but roughly speaking, the combination of fecal immunochemical testing, or FIT testing, with Cologuard genetic testing is over 90% accurate for cancer. When we talk about polyps, Cologuard advertises itself as being 85% plus accurate for advanced polyps. So what does that mean? It means that there is some trade-off, slight trade-off in terms of detection rates when you go from colonoscopy to non-invasive testing. But that being said, those tests are repeated more frequently. So hopefully they will be detected at an early stage.
In that shorter interval of time.
Precisely.
Look, I think most patients would take heart in the fact that the screening is so effective. Again, these are stats you almost certainly wouldn't have committed to memory, but in the grand scheme of scanning for cancer and for having visibility into a possible positive cancer diagnosis, it sounds like in this particular type of cancer, you're achieving a pretty high rate of understanding as to what patients have.
Without a doubt. And not only that, I can tell you, as chief of the division here at Atlantic, I am committed to quality metrics. And what does that mean? It means that every doc that does an endoscopy or colonoscopy here adheres to certain performance standards. That means that we get the scope to the beginning of the colon, and then we withdraw. And on that withdrawal from the beginning of the colon, we take our time and we're looking around. We're checking behind every fold and every crevice of this organ, which does not have to be a tubular structure at all. It can be quite twisty and turny. But we have a minimum withdrawal time of 6 minutes, and we expect to find polyps in roughly 1 out of every 4 patients that undergoes screening colonoscopy, meaning they have no symptoms whatsoever. 25% of patients will have polyps.
How shocked are they when they're told?
Some people expect it, some people don't. Usually it's you can often predict who might have it based on family history, based on whether they've ever smoked cigarettes. You can often tell if they're heavier drinkers. These are all contributing factors for colon cancer. These are known risk factors. But that being said, we often find colon polyps in people who have lived sin-free lifestyles. And
teetotaling all the way.
Exactly. And, I used to work up at St. Joseph's Hospital, and I've done many a colonoscopy on a nun. And they can have polyps just the same as the rest of us, as blessed as they are. So it's.
We have one more question before we run out of time. And it actually touches on something you addressed a little earlier. So this is actually good because we never know when viewers jump in. So what sort of preparation is there before having a colonoscopy done? We touched on it, but if you would reiterate, that'd be great.
So the prep is often discussed, but it's really not that bad. First of all, you should know the old prep was considered the standard, and it's still available for patients who request it. It was Go Lightly. Go Lightly is a gallon, a big
like a
jug.
big drink, right?
Yeah, it's a gallon of clear liquid. It tastes, how shall I say, like pickle juice.
Interesting.
Exactly. It's really not that bad, but it is a labor of love to take this gallon of foul-tasting liquid in over the course of a few hours. Now, we've changed the prep. We often do what's called a split prep. So you'll do half the prep the evening prior to a procedure and half the prep the morning of. That may require you waking up very early, but essentially if you're done with the prep about 2 hours before the procedure time, you're golden. And actually, we find that if you split the prep into 2 halves, it's better quality and better visibility for the doctor when the procedure is performed. So we want to encourage split preps for most patients. Preps have shrank in volume. We are now no longer giving the full gallon. We're giving smaller volume preps, and there's a variety of them out there. The smallest are probably the size of this water bottle. You'll take that prep. This is the foul tasting part, and then you dilute it with 2 glasses of regular old water. So it takes the suffering away to some large extent right there. And we give that prep again in a split prep format. But there are a variety of preps. Docs like to give Miralax and Dulcolax combination. We now have a tablet prep for the first time where you just swallow the tablets and dilute those tablets with water. Quite honestly, in the name of the prevention of colon cancer, I need to encourage our patients to just deal with the prep.
It's never been easier from the sounds of it.
Exactly. You have to do it. You just have to do it. It's a rite of passage in this lifetime, and we will all go through it, hopefully. And let's do it for the sake of our own health.
Amen to that. I'm nearing 45, so I look forward to it myself.
See you soon.
See you. Dr. Grossman, thank you so much. This was great, folks. I hope you enjoyed our conversation. If you missed any portion of it, perhaps you tuned in late and want to catch up, please, everything is located on our website, atlantichealth.org, or you can subscribe to our YouTube channel where all of these are listed as well. You can just search Community Conversation and everything will pop up there. If you want to learn more about any of what we talked about today, go to our the specific section of our website, atlantichealth.org/colorectal cancer screening, all one word, and you can find everything there. Dr. Grossman, you've been an excellent guest. Thank you so much for coming today.
Thank you for having me. It's been a pleasure.
All right, folks, we'll see you next time.